Is it F7 that syncs it or something?
Yeah, there should be a mirror option, right?
I'm not a Windows guy. Where is our?
Is that it?
Maybe. Oh, that might have been it.
What's that little square on the bottom? That.
Task view. So that's what these are. So let's look.
Maybe my assistant might know. Let me see.
Let's look for something about settings. Display. Display.
Hey, Zach.
What are you giving away?
What? My parents are here? Hey, Mom.
How do you mirror display? The other side.
They went the wrong way, huh? Hi. Hi. Hi, Dad. You guys didn't come in this door, huh? That's Zach. Okay. All right, Zach. They're having trouble with the equipment, like syncing the slides, because they don't know Windows. Do you know how to do that or no?
I can have a look.
Oh, I think they got it. All right. All right.
Do we have any seating arrangements?
Where, be as close as you like.
Down.
Yeah.
Come on.
Dr. July.
Yes.
That's my mom and dad.
Oh, really? Oh,
They took an Uber here from Woodland Hills. She's the cause of all. She's always the one who says, you should do yoga with your patient. She does yoga.
She's pretty good, my God.
I know.
It's always this, it's surprise time.
Do you need a laser pointer? Would you like a laser pointer?
I don't. How does it work?
You just press the button. And, well, maybe we'll get you a working one.
I don't really. It's okay.
And also, when you there will be a Q&A session after.
Okay.
And then if you
Repeat the question. Mom, he went to Lenny Lenape. Oh, no, she's, oh my God. That's not good. Hope I didn't break this thing. Okay. Do you think I broke it?
No, that's fine. So
How did it come off?
I had no idea.
It's very loose. Maybe I'll put it up here. And then it will fall down to the button.
Okay, let's stay there.
I think the button will protect it.
so we can begin our program today. If I could ask some people in the back to close the doors, that would be wonderful. So welcome back to Semel Street Grand Rounds. You will find outside in our foyer that we have a number of different pieces of paper today. We have a number of handouts from our speaker, Dr. Donna Ames, which are for your benefit. We also have two different evaluation forms, one for our course and one for her academic dossier, so please complete them both. They're not equal to. And we all appreciate your completing those things so that we have that for feedback. To introduce today's speaker, we have our own Dr. Steve Martyr, who you heard a few weeks ago speak, who is our Vice Chair for Education and Director of our MyRec. And without further ado, Dr. Martyr.
Thanks. It's a pleasure to introduce Donna Ames, who's been my colleague for many years. Donna is a professor in our department. It's good to see her come over from to the east side of the freeway. She at the West LA VA, she plays a key role where she runs a unit that's focused on psychosocial rehabilitation. To give a perspective on her talk, many years ago, when after the introduction of newer antipsychotic drugs, when we were all excited that these drugs seemed to be much easier to prescribe than older drugs, Donna was among the first to appreciate that these drugs have serious side effects. She was among the first to publish about their effects on health, particularly on cardiovascular health, and she continued to do a series of studies which I think led her to the idea that when you treat people with serious psychotic illnesses, one needs to bear in mind their physical health. She went much further with this idea and developed really the idea that for recovery, one has to take much more holistic view and looking at the entire person, their physical health, their mental health. She's done very innovative work looking at the role of arts and yoga and exercise and other things to really amplify how clinicians can actually promote recovery in people with severe mental illness. So I'm delighted to introduce Donna Ames. The topic is holistic recovery-oriented approach to the treatment of serious mental illness.
Thank you. I'm just trying to check to see if I have both these microphones on. Testing, you can hear me here? And then I can't tell if this one's on or not.
We're good.
We're good? We're good? Okay. All right. All right, so it's really an honor and a pleasure to be here to speak with you today. Thank you so much, Dr. Martyr, for your wonderful introduction. I've been at UCLA and the VA since 1988 is when I first came to begin my residency. So I love working here. I love working with the veterans. It's a tremendous honor. Every day I wake up looking forward to coming to work. So this is my disclosure slide. Most of my research has been supported by the VA Merit Review programs. I've also had some grants from the Disabled American Veterans Charitable Trust and some funding through the VA Central Office for dissemination of some of the innovative programs that we've developed over the years. So when I first began doing research here, I had the honor of working with Dr. Martyr and Dr. Van Putten, and we were really doing some innovative work with new antipsychotic medications, really This was my primary focus of my research in my early career, was learning about new medications for the treatment of schizophrenia. And then we started moving also into collaborating with Dr. Robert Lieberman on combining medication treatments with optimal psychosocial rehabilitation types of strategies, such as social skills training, which is an evidence-based treatment for mental illness. Over the years, the idea that a person with a serious mental disorder could recover has taken hold in our world, and this is a statement about achieving the promise of recovery. We envision a future when everyone with a mental illness will recover. A future when everyone with a mental illness at any stage of life has access to effective treatment and supports essential for living, working, learning, and participating fully in the community. What is recovery? Mental health recovery is a journey of healing and transformation, enabling a person with a mental health problem to live a meaningful life in a community of his or her choice while striving to achieve his or her full potential. This whole idea of recovery seemed kind of novel to me, coming from pretty much a biological focus, a psychopharmacological focus, that we could do more than just treat symptoms, but we could actually help people live meaningful lives. And for those of you familiar with Viktor Frankl, Man's Search for Meaning, I think that's really key. Americans are often very concerned about being happy, and Viktor Frankl basically said, it's most important that we find meaning, and happiness will follow. When you wake up in the morning, you have meaning in your life. So imagining going beyond just helping a person with serious mental illness cope with symptoms, but actually waking up in the morning and knowing that you're also going to help them find something meaningful to do, to have a sense of purpose, that's what drives me every day and what I enjoy doing with working with our veterans. The recovery model came to mental health from work from our substance abuse colleagues, and we've tried to come up with kind of a unified conception. SAMHSA has these 5 recovery domains: home, mental, physical health, purpose. Again, there's that meaning. What is the person's purpose? Community and independence. So going, again, beyond just symptom relief, but affecting these aspects of a person's life. Recovery, there's also, SAMHSA has a little wheel and some very nice handouts. I have a few of these that I can share with you on its working definition of recovery. The aspects of recovery seem to change, but one of the things that I'm going to be focusing on is the holistic aspect of recovery. And when I was in medical school, we would talk about a biopsychosocial formulation for the treatment of a human being. And I think recovery goes beyond that. It's beyond biopsychosocial. It's also spiritual, too. So I will be talking about the different work that we've been doing to help veterans in these 4 spheres: biopsychosocial, spiritual. Approaching veterans or approaching people with serious mental illness in a holistic manner isn't a new concept. There was some work by Dr. Robert Lieberman and colleagues back in 1986, where a holistic program was provided to patients in 10 weeks in hospital. And the holistic program included exercise, meditation, stress management, positive thinking, and family therapy. And basically, that was compared to the evidence-based psychotherapy of social skills training, and both groups improved. However, the holistic wellness group had larger treatment effects. So to me, this study was marvelous because it really motivated me to further this kind of work, a holistic approach to the treatment of serious mental illness. In 2011, I read a position piece by a guy named Roger Walsh, who's at UC Irvine, and he talked about the importance of psychiatrists approaching not just people with serious mental illness, but all mental illnesses, using lifestyle as part of our interventions. And he had hundreds of references supporting 8 key elements in what he calls therapeutic lifestyle changes. Roger basically stated that by doing lifestyle changes with our patients, we can really affect great changes in their mood. There's great evidence basis for exercise being good for not only depression, but there's actually trials showing that exercise helps people with schizophrenia. So I'll go on to show you that these are the 8 things that Dr. Walsh put together as things that psychiatrists should be thinking about. Exercise, nutrition and diet, time in nature, recreation, relaxation, stress management, religious and spiritual involvement, and community involvement or volunteerism. So I was very inspired by this paper. It touched me because I was working at the time at developing a psychosocial rehabilitation and recovery program, which we'll talk a little bit about, at the VA. And that was a novel program. The VA decided to change the way we deliver treatment to persons with serious mental illness from day treatment programs and day hospital programs to psychosocial rehabilitation programs, emphasizing getting people into the community. What a novel concept. We weren't going to be outpatient institutionalizing people and coming to a program where we did things for them. They'd be coming to a program where they'd be encouraged to recover and get into the community. And so when I saw this paper, I said, this is everything that we need to be emphasizing in our clinical care of these persons. But I also have been involved in committees at the VA on the health and welfare of employees. So I'd like everybody in the audience to look at these 8 things yourselves and ask yourselves, how many days a week are you getting enough exercise and not eating your lunch like I do half the time by the computer, crumbs falling on the keyboard? So eating mindlessly rather than mindfully. How many days are you spending time noticing the beauty around you, enjoying yourself, having fun? So all of these things speak to not just the treatment of people with serious mental illness, but every one of us. These are 8 things that are really helpful in all of our lives. And trying to do all 8 things can really improve the quality of our lives, I believe. So also, therapeutic lifestyle changes can be cost-effective. As Dr. Martyr mentioned, in the kind of arc of my career, I was involved with clinical trials, phase 2 studies with Dr. Martyr, trying the newest medications, and then being the junior kid on the team, noticing in the care of the patients in these studies, they were gaining an awful lot of weight. So we went from the first generation medications with their side effects of neurologic side effects, drug-induced Parkinsonism, akathisia, tardive dyskinesia, and then we got to these new medications, and our team, being people who got our hands on these medications first, were amongst the first to notice they developed diabetes, obesity, and hyperlipidemia. So that's not good. Those are not good things. However, these medications were generally more acceptable to patients because the neurologic side effects were so untenable for many of them. I saw miraculous changes in many people that we were able to put on these new medications. But when you combine obesity and the diabetes on top of a costly illness like schizophrenia, you have a major health problem. So most of my career, since I guess about 2006, most of my research has been focused upon trying to reverse the side effects of these medications, realizing that many people with serious mental illness have to take these medications. Most of the grants I've had have been focused on providing ways of reversing behaviorally weight gain. I tried medications in some patients, but I was most impressed that medications don't work unless you get those behavioral changes. So most of my research for the past 10 years at least has been on applying a multimodal treatment for weight loss in patients with serious mental illness. This is a slide I put together on a few studies that were done. The RAISE study by Keane and colleagues and commented upon by Rosenheck, in which a multimodal approach to the treatment of people, not yet, like early on in their illness with schizophrenia, but basically patients were provided not just medications, but they also had psychological support, social support, job training, and other interventions. And they had better outcomes than those patients who were just coming to the mental health clinic for medication management. And not surprisingly, Dr. Rosenheck stated that, that this kind of multimodal approach was highly cost effective, comparable to the cost effectiveness of giving people statins. It was to prevent heart attacks. So I thought that was really impressive. And again, I was involved with the development of a very large research study in 2006, which finally wrapped itself up and got published in 2014. 9 sites around the country comparing injectable risperidone to every other oral medication for the treatment of schizophrenia. And I think going in, the hypothesis was the injectable would do better than any oral, no matter what, in moderately refractory patients who had schizophrenia. The end result, basically, there was no difference between the injectable and every oral. And the reason I believe, and most of us took away from that study, a very large study, 9 sites around the country sponsored by NIMH, was that the people were being seen every 2 weeks in both arms. So is it the injection or is it the frequency of seeing people? So to equalize the frequency in both groups, the oral medication groups had to come in every 2 weeks. So this slide very briefly summarizes what I mentioned has been my major research funding has been for management of antipsychotic medication-associated obesity through the VA merit review system. And we provided group classes, individual case management for people with serious mental illness to help them with weight loss. We also had incentives. It was a very aggressive behavioral approach to the treatment of weight gain in these folks. And we had good success. We tested this in about 240 patients. We did one study with 120 patients in one site and then broadened it to 4 different hospitals within the Los Angeles VA. And it's interesting that while we were doing this work, the management of antipsychotic medication-associated obesity, I started thinking we're really focusing on 2 things, exercise and nutrition. But what about those other things that Roger Walsh was talking about? Could we look into that a little bit more? Because when a person struggles with obesity, there's more to it than just changing exercise and diet. Because for those people who might be familiar with Overeaters Anonymous and these kinds of things, it's not just what you're eating, it's what's eating you. And so I wanted to look at this, and I asked the dietitians working with the patients in the studies to start asking veterans and non-veterans in the study, how many of these TLCs that Roger Walsh mentioned are they doing? To get a sense of, how does that affect the weight loss we're looking for? So we also did a little scale. I'm a pragmatist, I'm a clinician. I see patients, and when I see patients, I really want to have quick and dirty scales that don't take a lot of time. So I wanted to measure not just, symptoms, but I was thinking, what about biopsychosocial spiritual scale? Some quick and dirty, 0 to 10, 4 items. So we started testing this scale in our Mamio study, the biopsychosocial spiritual scale. We came up with 4 statements and measured 0 to 10 to kind of get an idea of how are people doing in these 4 realms. So just in terms of what we found in our Mamio research study, the weight loss research study, we noticed that people who did more of the TLCs that Roger Walsh was talking about, that more of the TLCs that they did also correlated with higher scores on the BPSS. Additionally, we found that more TLCs practice was correlated with more weight loss. So that was encouraging as some pilot data. We did a second pilot study where we actually developed classes for each of the 8 TLCs that Roger Walsh was suggesting. And our goal was to track the kinds of behaviors that we were hoping to see in these patients. And so we actually found that after getting classes and individual coaching, at each time when the patients came in and met with us, we came up with goals for each of these 8 things. And so we did find that patients increased healthy behaviors. We saw improvement in quality of life, and they had decreases in blood pressure. So those were encouraging pilot data. Now, getting pilot data and convincing a review committee of any kind of research place, I got these 8 things, and if we put them all together, I think it's going to really help patients. They look at you like, are you out of your mind? Science is reductionistic. Just do one thing. Just make them go for a walk and then measure, right? So I can tell you, I feel like I intuitively as a clinician know that this is really helpful. And I approach every patient with this now. Every patient that walks in my office, I give them 8 TLCs and I start working with them little by little to change their lifestyle. And I feel it's really intuitive, but convincing a granting agency. If any of you in the audience can help me on this, I'm struggling. Anyway, but we do have some pilot data. So weekly TLC journals were done for these patients, and we did show that they had improvement in TLC practices. Their quality of life improved. And then, trying to convince National Institute of Health what the mechanism is by which all of these 8 things. Any of you writing grants for NIH know what I'm talking about. This is challenging. Okay, so we also looked at changes in the World Health Organization quality of life, and again, we saw improvement. Okay, so this is my humble little worksheet that I use every day with my patients. And I even think about it with myself. So I really recommend it for everybody to be thinking about these 8 things in your own life. In terms of like prevention of Alzheimer's disease, in terms of most health-related illnesses or preventable illnesses, the top 2 that we know that really matter are exercise and nutrition for longevity, everything. So I spent a fair amount of time talking to my patients about these things. When they come in my office, I measure vitamin D levels, B12 levels, folate levels. I see what's going on with their thyroid. I figure out if they're having sleep apnea. There's so many things that when veterans come into my office, I think about that biological that is going to be affecting the psychological, right? I can't even tell you how few prescriptions for antidepressants I've had to give when I've reversed things in patients by getting them on a sleep apnea machine. Or now the VA and DOD guidelines for PTSD, you don't go to medications. Medications are not the first line choice for the treatment of PTSD. Therapy is. But I think these 8 things can really help people with PTSD. And when they come in my office, I work on it. I'll put them on fish oil and multivitamins and make sure they're getting the right kinds of therapy. And we don't have to use antidepressants right away in patients with PTSD, not according to the VA DOD guidelines. So these are the 8 things that we asked our patients in the MAMIO study and the pilot study, and these are the things we coached patients to do. We put together a little poster about our findings, and this is a screenshot, I guess, of the publication on the pilot studies. And then, basically, for the past 10 years, I was working in the PRC. I was helping to do a major systems redesign to change all day treatment programs to day hospital programs to the PRC, as I mentioned previously, and to embrace the recovery model. And so, of course, when in my clinical role, I wanted to make sure that all people coming to the PRC were getting this holistic approach. We put together for people in the PRC, and again, you can use this with patients in your office in any kind of practice setting. Even on the inpatient unit, we would start off with something called a recovery plan, my personal recovery plan, and get a sense of where patients were in terms of their physical needs, their social relationships, their meaningful activities. This is different than a treatment plan. This is where the person in your office and you are collaborating, and you're trying to figure out with this person, what are your strengths, what are your needs, what are your preferences? We talk about SNAP. So this personal recovery plan, we'd ask the person to write down their goals and their dreams. And it's a very different approach than a treatment plan. In a treatment planning, you're often writing down a person's problems. Here, using the My Personal Recovery Plan, we want to know the person's strengths. And it's a very different conversation you have with a person. You're asking them, what are your strengths? What would you like to do with this life you have in front of you? And very eye-opening. And when I started working and sort of learning about the recovery model and trying to apply the recovery model with patients, it was like a shock. I wasn't telling them what to do. I was asking them what they wanted to do and trying to help recommend some coordinated services to help them with their dreams. If anybody's ever tried to keep New Year's resolutions, anybody, right? You know what? The most of us who don't keep New Year's resolutions, the reason is we don't write it down. So if you have a recovery plan and you work on it with your patient, you can go back to them and say, what was your recovery plan? And it's very refreshing for those of you involved with ACT therapy, acceptance commitment therapy. This is like what we're trying to do is talk about the future, where you're going. We're not focused on the past, though, with recovery we want to be sensitive to traumas and things that have happened in the past. But when you're having a discussion about the person's recovery, and when they come in your office, okay, let's talk about this. The last time I met with you, you wanted to get out of that board and care and get into your own apartment. What are you doing on that? Where are you moving on that? So I know from my personal recovery plan being in the person's chart what we're working on, and that's part of our discussion. And for me, as a clinician, it's very rewarding seeing these changes. And everybody has their own kind of arc or trajectory of recovery. It's not the same for each person. But I've seen people in their 60s with chronic schizophrenia go back to college. I've seen people who never thought they could work go back to work. And to me, that is so rewarding. And when you're working with veterans or persons with serious mental illness, it's very easy to jump in and want to do for. But what we're trying to do here is do with and encourage as much self-efficacy as possible. So at the PRC that we developed, we made sure to have evidence-based treatments. These were all mandated when we did the systems redesign. Work and school support, we provided wellness. I got a grant together and we got a kitchen made in the PRC, and we also got funding and developed a garden so that we could have people work in a garden and cook the food and learn those skills. We had creative arts, mind-body treatments, community integration, outings, and activities. Well, we developed a self-government for the veterans to run their own program, and we brought the chaplain in and had a spirituality group. The evidence-based social skills training, all staff were trained in this for conversation skills, symptom management. These were all developed by Dr. Martyr and Dr. Liberman, and I was involved in the early research, some of the early research on social skills training. These were all things we provided. We also worked on computer literacy with the veterans. Again, I got some funding, got some computers into the program. Workplace fundamentals. There were 3 different kinds of work programs at the VA: incentive therapy, which they're phasing out, and transitional work experience, and supported employment. Supported employment is an evidence-based treatment for people with schizophrenia, and I have also read with great excitement it's being tested in working with persons with PTSD, supported employment, which I think is very important. I think the idea that somebody has to come back from military duty and be disabled rather than unable to work is a tragedy. I think that people can work and can feel better from working, giving them, again, meaning and purpose. I saw a veteran who had been suicidal on an inpatient unit after retiring from a long career. And I looked at him, I said, you know what your problem is? You need to work. He said, you're right. And he's gone back to work. No more suicidality, no more depression, and he's happy again. He has meaning. He just said he was going crazy sitting at home, not working. So, sometimes we really have to think, what is this person doing that you derive meaning from? So we had wellness classes at the PRC, food, fun, and fitness, brain health, mindful metabolic. These were all taught by a nurse. And we had some creative arts classes, creative writing, really fun to see the kinds of things people can write about. We would publish a journal every year from that class. And over the years, we had different creative arts classes such as music appreciation, film and art appreciation, and dance. And I worked with Dr. Rubin, Dr. Robert Rubin. He helped spearhead the development of a program that we got some funding for called Dance for Veterans. And this is the fellow in front. He's the lead dancer for the Mark Morris Dance Company in New York. they developed a program called Dance for Parkinson's. The notion being that when you dance, you can fight the Parkinson's disease. It's pro-dopaminergic. And so I thought, that's great. I think for people on dopamine blocking drugs, dancing might be really cool too. And I was very interested in yoga and dance, and I would tell you from my experience, we got the dance program going. We worked with 3 graduate students here at UCLA in dance, and we developed a manual. We started disseminating it to every PRC within our VA, and it was so joyful to see people who, part of some of the symptoms we see with people with schizophrenia can be the negative symptoms, the lack of emotional expression. But when you see people dance, there's an inherently social aspect to it. And more so than you see with yoga, which is more like you're in your kind of own zone. But like with dance, there was a lot of the exercises we developed came out of a comedy improv. Comedy improv actually was started by a social worker in Chicago dealing with immigrants who had come from Poland, didn't know how to speak English, so they started doing all these fun games. So with our dance class, we have a game, it's called the name game. So you'll say a name and you make a movement. Like, my name is Donna, Donna. And then I would go to the next person in the audience and you would make a movement. So, so we would learn each other's names. And so it's a fun thing. And it was wonderful to see people with schizophrenia, with cognitive impairment, doing really well at learning everybody's names, like up to 10, 15 names in a room. And I'd say to them, now I can send you to the grocery store. You're going to remember 10 or 15 groceries. So these are some of the aspects of the Dance for Veterans program that we developed, and we published this. Sarah Wilbur, she was getting her PhD at UCLA. She's now at Brown. She was the lead author on that paper. We surveyed about 81 persons involved in the dance programs throughout Los Angeles, and they truly enjoyed it. We had good feedback from them. And these are some subjective or comments. They were saying, this is the highlight of my week. It lessens my stress levels. My mind will today dance. At first, I did not want to come, just stay isolated. Now I look forward to coming every week. So then the key for the recovery model would be, once they learn how to dance here, can we get them interested in dance classes in the community? And I had one veteran yesterday tell me that he was now partaking in some competitions in the community. He told me it was something called urban ballroom. Sounded really interesting. This was Sarah's paper on the development of the program. We used focus groups and really got some feedback from various stakeholders in developing the Dance for Veterans program. If anybody's interested in any of these materials, by the way, I'm really happy to share these things with people, and loved opportunity to disseminate these things. Over the years and running the PRC, we had yoga, tai chi, qigong, mindfulness and dance, mind-body treatments, which I think are really important in helping deal with stress and anxiety. When I started getting interested in yoga, it was thanks to my mom, who's sitting here in the audience. She said to me, I take yoga, you've got to do this with your patients, you're going to love it. And so I listened to my mom. It took me like 45 years before I started listening to her. And we did, I questioned whether yoga would be helpful or not. So a young woman working with me one summer, we did a little meta-analysis of all the studies on yoga for depression, anxiety. I think there was one study for schizophrenia. And she met with a statistician. And what we learned was there was very few really good RCTs at the point that we did this meta-analysis. This is a few years back. And what we learned was that for the the effect that we saw in these few well-done RCTs, there were 10 of them, you'd have to have 200 negative studies to discount the impact of yoga for depression and anxiety in particular. So that was pretty compelling. I thought maybe this is worth exploring more, how we can use yoga in our patients. And we did get funding from the DAV and from the VA to further develop yoga classes, which we called breathing, stretching, relaxation. They were devoid of any Sanskrit, mostly because I am really bad at other languages, and it was just, I said, if I can't learn these words, let's just keep it really simple. And so breathing, stretching, relaxation is just really straightforward. We developed a 10-minute, a 30-minute, a 60-minute classes. And I was getting, so really good feedback from patients. They said, I love yoga, it's not girly. Yoga quiets my voices. So I even had people with schizophrenia enjoy the yoga classes. But again, from my perspective, I really like the idea of using the dance, particularly with the negative symptom folks with schizophrenia. So we did administer surveys to people taking the breathing, stretching, relaxation classes. We had tremendous support from the Office of Patient-Centered Care to develop these things and disseminate them. I think about 900 employees got exposed to our 10-minute breathing, stretching, relaxation classes as well. So these were some of the things we collected when we collected surveys, and we had some statistically significant results from the surveys about pain and the relationship between pain and enjoying the classes. It makes sense. It's interesting to me that veterans who attended more classes reported greater physical well-being. So I think there's more questions to look at regarding breathing, stretching, relaxation. Again, I have a Train the Trainer manual that we developed for this. We have materials. If anybody's interested in our protocols, we have published these things. This is what the BSR class looks like. You can do it with any body habitat. Habitus? This is a seated class. And so veterans truly enjoyed it. We brought in, as I mentioned, into the PRC a spirituality class. We brought a chaplain in to help, again, a holistic approach for our veterans. And over the arc of my research career, I've become more and more interested in the spirit and spirituality and how that impacts our veterans' lives. And I started working through the chaplain at our VA with Harold Koenig, who's an expert in religion and mental health and religion and its impact on other health outcomes. And Dr. Koenig from Duke asked us if we could explore the prevalence of moral injury in patients at our VA, along with hundreds of other patients. Moral injury is a concept that's been around. Many of you may be familiar with it, but it's the idea that certain events are perceived as morally injurious, where you do something wrong or somebody else does something wrong that you respect, and then you suffer this kind of inner conflict. Another term for moral injury that's getting used is inner conflict. So sort of the consequences of moral injury or inner conflict, as Dr. Koenig described it, is a pure guilt, shame, self-condemnation, feelings of betrayal, difficulty forgiving, loss of trust, meaning, hope, spiritual struggles, loss of faith. Now, moral injury is not the same as post-traumatic stress disorder. There may be kind of an overlap. They may travel together. So teasing out moral injury, there's been development of a scale called the MIES, Moral Injury Event Scale, where you can see if a person has had a morally injurious event. But what Dr. Koenig asked me to help develop is a scale to measure changes in moral injury over time. And I felt this was very important because 22 veterans kill themselves a day. And actually the number I understand has gone down to 20, but that's 20 too many a day. And these two veterans riding these motorcycles here, I met them, and they made a movie called Project 22. One of them was going to shoot himself in the head, and then he called his friend, and they got on their motorcycles to go across the country to help people understand more about this serious epidemic of suicide we have and raise awareness. And they were also feeling like whatever treatments they were getting for PTSD wasn't working. So part of their journey was finding other things that help treat PTSD. They spoke to a yoga teacher, and they went to a sailing class, and they found a person doing creative arts. They found a whole bunch of other things that people with PTSD were finding to be helpful. And one of the things that caught my ear while they were talking was they would talk to people, and they were on all these medications and feeling like zombies, and you'd hear people say repeatedly, I feel like my soul was ripped out. How do we fix that? So I've been working, like I said, collaborating with Dr. Koenig, and so the next place I'm going in my career with my research interests is to help come up with interventions for moral injury. And I've been speaking to chaplains all around the country because I think we have to partner with chaplains and people in the community to help raise awareness and help give them tools to help people with this. And so we're also developing a spiritually oriented cognitive processing therapy, which we have just published a long, these are some of the things that we're doing. We've developed a long interview for moral injury. And me being a pragmatist, I said to Dr. Koenig, we got to get a short one. I can't do this. This is 45 questions. I got 15 minutes max. So we developed a 10-minute one too, and that's been we're showing that to be valid, and then we'll be looking at that when we try to do interventions to help people with moral injury. And we collected about 500 surveys here in Los Angeles and elsewhere, and found a very high prevalence of moral injury in veterans. And so who can help these people? Chaplains, psychologists, depending on the person's interest. If you're in a rural area, a person may not want to go to see a psychologist, or maybe stigma. So they may want to go to a church or to their pastor. So that's why networking with people in the community is going to be very important. So to sum things up, recovery embraces a holistic approach, biopsychosocial, spiritual. And it's just been an honor and a pleasure to work here at the VA and UCLA. And our PRC was recognized recently by the Office of Patient-Centered Care for strong practices, particularly for the dance and yoga research that got implemented there. So thank you very much for your attention.
Well, thanks for a wonderful talk. We have time for questions. Yes.
I thought your presentation was really excellent, and the evaluation sheet seems to have been the first two questions are from last week, but I think they're using the parts of this program that you're talking about, the full service treatment program that the county is providing for persons at risk. And I'm wondering, you've been excellent in terms of retrieving resources to enable the holistic approach, and I don't know how well the full service program is been evaluated. evaluated yet, but that connection to resources seems to be very, very important. And so I commend you. You really put your heart into it, and I think this has really been very informative. So the personal recovery plan is something really, I hope, if I were still working, I would certainly use that, but I commend that excellent idea. Thank you.
Dr. Ames, I am actually a health coach, and I know it's off topic for this presentation, but I'm really interested in talking with you about programs for employees.
Mm-hmm.
So I can email you whatever. That's my main interest. Thank you.
Donna, in a time of depleting resources, part of the advantage of what you're recommending is how complete it is. But but clinicians oftentimes have to prioritize things. I mean, how do you do that in a clinical setting? For example, if somebody is young, since, in the first few years of a serious mental illness, how do you sort of decide what kind of program they would need, or what would you wrap around them?
Okay, that's a great question. I think with diminishing resources, I had to be very clever at finding a lot of volunteers who wanted to come and teach yoga or dance or whatever in the community. But where I would start with any person, I think a very good starting point, and I work in the mental health clinic, so I see hundreds of patients. So I don't have as many resources as I did in the PRC. It's a different model there. So what I do is I start with my personal recovery plan. And that plan guides me. And then I start with those 8 things and then try to figure out which one of these can we work on. Because if you try, and the health coach probably knows this, you will overwhelm people if you try to do all 8 things right away. But let's pick one. Okay, so this is a young person, say, like Dr. Martyr says, and we want to avoid weight gain. Let's talk about our diet right away. Let's see if we can make one improvement, provided that's something they're interested in. But my personal recovery plan is such a good way to start this conversation. If it's a young person and they want to go back to college, how are we going to help them with that? So I am learning to basically apply what I learned in developing the PRC in a one-on-one situation with very little resources in a mental health clinic. So I know exactly what you're talking about. And then trying to use whatever community supports we can figure out to help provide for these patients. It is a challenge. And with diminishing insurance reimbursements for different things, it is quite challenging. But how can we find community things? Like I found there are free computer literacy classes in the community. So when you're dealing with the recovery model, you're really trying to figure out what are the resources. If you have an older person who's very socially isolated, one of our recovery model thing in my personal recovery plan might be getting them to a senior center so they socialize more. So of the 8 things, I will have people come in and I'll say, how many conversations are you having a week with anybody? 0? Okay, guess what? We're going to make a goal. You have to have 1 conversation every day with somebody. I don't care if it's a grocer, whatever. But we will come up with a goal that's reasonable, that they can increase the level of conversations they're having. But we have to do these things incrementally and slowly and not push people to go too fast or to make too many goals. We create SMART goals, specific, measurable, attainable. I'm forgetting what R means right now because I'm tired. Realistic, there we go, and time-bound. You create a SMART goal for each of those 8 things. But really, you have to be very clever and you have to be resourceful and find out what community things we can offer if you're working in a mental health clinic where there's not a lot of those resources.
Thank you for this stimulating talk. You mentioned advising PTSD patients to take multivitamins and fish oil. So I wanted to ask if this is a general practice that you do with all serious mental illness, that you advocate for this, and if you have seen any remarkable results with this, especially for patients that are not on any other psychiatric medication. And is it that you would advise for multivitamins or any particular vitamin or mineral that you focus on?
That's a good question. One of the things I want to make sure I clarify. With when we look at a person, we want to make sure their nutrition is good. The best medicine you can have is a good diet, period. So supplements may or may not really help, but one of the first things I'll do with a person with any mental illness is talk about their diet, what they're eating, and try to analyze that. And so I'll give them a food and exercise diary to kind of figure that out in part. And then I will order a series of blood tests to see if there's any nutritional deficiencies. So I'll look, like I mentioned, vitamin D, it seems to be ubiquitously low in almost every person I run into, and even myself, because we don't spend enough time outside. And in my dark-skinned patients, it's almost constantly low. So vitamin D supplementation is pretty harmless and something that I'll recommend. And especially as I'm trying to sort out and do different psychometric tests on patients to determine if they really would benefit from an antidepressant. So if a person with PTSD also has a very severe depression, and we're trying to sort out if they would benefit from an antidepressant in addition to their treatment for their PTSD, we want to get those blood tests in, and we want to do psychometric tests to see if they indeed might benefit from the combination of an antidepressant with their psychotherapy. But doing a very good holistic workup, it requires you to look at the whole person, check their blood pressure out, check their thyroid. We have people who are very anxious who come in, they're hyperthyroid or they're tachycardic because they actually have a cardiac condition that makes them think that they're anxious. So we want to try to evaluate the person medically thoroughly. That's my approach. And I'll try to get the person in very quickly, get those blood test results. Glucose irregularities. If your blood sugar is going up and down, you're going to feel anxious. You're going to feel panicky. So I want to get my hemoglobin A1C. I want to get my blood test on these folks. So I just approach each person like a fresh, look. I'm a medical doctor and I want to know, are there any medical things that could be causing or, complicating these issues? I saw one person and did a series of blood tests. Turned out they had pancreatic cancer. And they thought they were having panic attacks. But their whole metabolic system was really out of whack. So sometimes you find these big issues. Another person came in with PTSD. Turned out, he told me he was having terrible panic attacks. Turned out he really had a cardiac arrhythmia and a mitral valve problem. So we don't want to neglect that. And it's very easy with our seriously mentally ill people to forget. And then if we put people on psychotropics that are going to cause weight gain, we should have a hemoglobin A1C. We should have some basic blood tests. So if they're going to get diabetes, we can follow this.
Okay, thank you very much.
All right, thank you.